You walk into a sterile room, and your patient is suddenly pulling at their IV lines, unable to recognize where they are. In this exact moment, you have to answer one critical diagnostic question. Are you looking at delirium or dementia? Delirium is an acute, rapidly developing condition. It usually spikes after a sudden trigger, like a urinary tract infection, admission to an intensive care unit, or polypharmacy, taking multiple medications at once. This split-screen chart illustrates the definitive clinical marker. On the left, we see a wildly spiking blood pressure graph. Delirium forces the patient's vital signs to become chronically unstable. Compare that to the right side. Dementia is a chronic, slow decline. Unless there is a separate medical issue, a dementia patient's vital signs remain completely normal. Because delirium stems entirely from a physiological root cause, it is fully reversible. Once you treat the infection, the confusion clears up entirely. Grave. Confusing delirium for dementia is a fatal error. Ignoring that vital sign instability means missing a life-threatening medical emergency that could have been completely reversed. Let's look at this diagram of a human brain viewing a cup. The visual recognition pathway is intact, meaning the patient knows exactly what the object is, but the speech generation pathway is severed. This is aphasia. The patient strictly loses the physical ability to generate the words to name it. Contrast that with agnosia. In agnosia, the neurological connection to recognize the item fails entirely. The patient can look at a highly familiar object like their own toothbrush and have absolutely no idea what it is. When managing these neurological deficits, providers often prescribe cholinesterase inhibitors, like donepezil. While they help with symptoms, they carry severe side effects: severe gastrointestinal distress and bradycardia, an abnormally slow heart rate causing the patient to pass out. Cautionary: these medications also set a trap. Combining donepezil with standard NSAIDs, everyday painkillers like ibuprofen or aspirin, creates a severe, immediate risk for gastrointestinal bleeding. Managing neurocognitive disorders requires treating the patient's physical environment and their pharmacological profile as a precise, highly reactive system. Moving from cognitive disorders, we shift to personality disorders. These are not physical brain failures or structural deficits. They are deeply ingrained, maladaptive psychological frameworks governing how a person interacts with the world around them. This triage matrix maps out the overarching structure. We have cluster A with odd and eccentric traits, and cluster C showing anxious and fearful traits. But watch the middle column turn red. Cluster B contains dramatic and erratic behaviors, representing the highest clinical danger. Within this cluster, borderline personality disorder acts as the primary internal threat. These individuals operate under an extreme fear of abandonment, making them highly impulsive and placing them at a severe risk for self-harm. Then we have antisocial personality disorder, which serves as the primary external threat. These patients show a total lack of empathy and a complete disregard for the rights of others, putting the nurse and surrounding staff at high risk for violence. Patients with borderline personality disorder frequently use a defense mechanism known as splitting. Their psychological rigidity forces them to categorize staff members as strictly all good or all bad. They cannot process nuance or gray areas. When dealing with cluster B, your primary clinical intervention isn't administering medication. It is maintaining absolute physical safety and establishing unyielding professional boundaries. External crises can abruptly shatter a patient's reality. We classify the loss of a home, belongings, or loved ones in sudden, unpredictable events like earthquakes as a situational loss. This is distinctly different from maturational loss, the expected developmental milestones we all face, like children moving away for college. But natural disasters trigger acute, overwhelming grief driven by immense situational displacement. The dual process model visualizes a pendulum swinging constantly between loss-oriented coping and restoration-oriented coping. This illustrates oscillation. A grieving person does not stay fixed. They bounce constantly between crying and mourning what they lost and the logistical necessity of adjusting to new roles. Sometimes the loss involves an unacknowledged or secret relationship. This is called disenfranchised grief, where a person is mourning a loss that society does not publicly accept. When navigating this, the nurse is strictly required to check their own personal biases. Clinical grief is never a straight line to acceptance. It is a highly unstable oscillation, requiring careful, unbiased navigation to support the patient through their shifting emotional landscape. Now, at the exact moment a patient enters hospice care, the clinical focus shifts entirely to the family. Your responsibility is to actively educate them on the dying process, to remove their fear of the unknown. Families must know exactly which physical signs to anticipate. You explain the incoming changes in skin color, the blue tint on the lips from dropping oxygen levels, and the natural gasping reflex so they are not frightened when it happens. And you must reveal the absolute final clinical rule. The sense of hearing is the last physiological function to leave the human body. Because of this, it is a strict nursing mandate that all professional or clinical conversations happen completely outside the room. At the bedside, you actively encourage the family to keep talking to their loved one, treating them as if they can hear perfectly. Mastering these clinical modules provides the expertise needed to stabilize and protect a human being when their mind, personality, or body ceases to function reliably.